All right, let's go ahead and get started. Thank you all for attending today. I'm Kevin Hiner, one of the psychologists here at Road Home Program at Rush University Medical Center, which is, um, you know, uh, the Road Home Program provides mental health services to veterans, service members, and their families, and is a part of the Wounded Warrior Project's Warrior Care Network. And I'm here to talk about ethical considerations for civilian mental health professionals or providers when treating U.S. service members. Just of note, when I put civilian mental health professionals, the aim of this uh, uh, talk is to really focus on non-defense health agency mental health providers. So folks that are not uniformed or civilian providers working within the military. So just a little bit about my background. I'm a licensed clinical psychologist. I work predominantly within the accelerated treatment program at Road Home, which provides primarily accelerated uh, PTSD treatment to service members and veterans. And I am an Air Force veteran myself. I am a former active duty Air Force psychologist. And while I am a veteran, the views that I share in here are my own and not reflective of the DoD. And I have no conflicts of interest or disclosures to report. But given my background, I think I'm in a unique position where I had worked as a civilian psychologist prior to commissioning into the Air Force and had to learn a lot about ethical issues when providing care within the military system. And then as I transitioned out of the military and continuing to provide mental health services to service members and veterans, how that might be unique compared to when providing within the system. The objectives that I have for us today are to identify and explain limits of confidentiality and informed consent as they apply to service members, to integrate military cultural competence into ethical decision-making and clinical practice, and to assess ethical dilemmas using the ethics codes and selecting appropriate actions. So when looking at this topic, I want to explore what the need is. We have ethics codes from the variety of career fields within mental health. And so why explore this when we can just go to the ethics code? Well, we know that there might be some unique things that are present with our service members. And how do we apply our code of ethics to that treatment? Uh, what I have noticed is that the literature predominantly focuses on the ethical issues as it relates to uniformed and civilian mental health providers within the Defense Health Agency, and even more so, really focused on uniformed providers. Um, and with that, there has also been an increased number of service members engaging in care outside of the DoD and outside of military treatment facilities, or MTFs is what I'll typically refer to it in the future. One research study from 2024 noticed that there was a significant increase in service members receiving off-base or off-post care from 2017 to 2024. In fact, it went from 9% of service members receiving care in 2020 or in 2017 was about 9% received off-base care, and then that sharply increased to 38% in 2022. That might be reflective of changes as a resulted from the pandemic, but there are a number of different reasons why service members might seek off-base care. And that could be limited availability within the MTF. There's been an increase in demand in services within the military treatment facilities, and there may be greater access or quicker access to care within the community. Service members also might have a preference for off-base care due to concerns about career impact or the stigma of engaging in mental health care within the military. Some of that might be due to experiences where Peers or superiors might have lost confidence in folks engaging in care, or um, have decreased trust in folks seeking care, or just concerns about being treated differently. There's also a number of concerns about folks gossiping about others, and perceptions that they're using mental health care to get out of work or to not deploy. And sometimes that might be a little bit more obvious when someone's engaging in care on base. Um, and then there is also some distrust of both military mental health providers or the system itself. Right, so there has been a lot of efforts to decrease the stigma of mental health services within an MTF. However, engaging in care can have significant career repercussions as well. So some of the distrust might stem from that. Additionally, service members in the Guard and Reserve may have limited access to an MTF, as they might be geographically separated from the closest MTF or VA. And so they may be engaging in care with civilian mental health providers. Additionally, I think that this type of training is important because some studies have indicated that the majority of non-Defense Health Agency or VA mental health providers don't feel fully competent in treating service members and veterans. In fact, only 24% of civilian mental health providers that take TRICARE, which is essentially the military's payer system for care in the community. So only 24% of civilian TRICARE providers reported high level of cultural competence when it comes to the military, and only 8% of non-TRICARE providers reported high levels of cultural competence. Furthermore, the APA in 2020 made several recommendations to the DoD as it related to care for service members. And these recommendations including increasing the number of mental health providers in the TRICARE network, which included appropriately reimbursing them for the treatment that they provide. So what we see is that there's more service members engaging in off-base care with civilians. There are a number of civilians who don't experience confidence in their cultural competency to provide services to service members, and there might be continued push for there to be an increased amount of providers engaged in the TRICARE network. So I mentioned that the majority of literature focuses on those military mental health providers, both uniformed and civilian mental health providers within the Defense Health Agency. And I think it's important to take a look at the ethical issues that are pointed out there, because some of that will be pertinent to and relevant to our discussion as we talk about civilians and ethical issues that might arise when providing treatment to service members. So this won't be fully exhaustive, but taking a look at some relevant ones. First one being multiple roles that military mental health providers might find themselves in. We know that and I will say, through a lot of this discussion, I will talk through the perspective of a psychologist, since that is what I am in. So I will talk more specifically about the APA ethics code. And since I also have greater experience within the Air Force, I'll speak a little bit more towards that, but then also talk more about the military as a whole. So when it comes to multiple roles, the APA ethics code really discourages multiple relationships in order to avoid any potential harm that might come to our patients. But what we recognize is that the nature of the military organization makes abiding by some of these ethical standards particularly difficult. So efforts to avoid multiple roles may be limited, especially in situations when the military provider is the sole mental health clinician on an installation or when they're in a deployed environment. So mental health providers in those situations may have contacts with their patients or who are service members in social and personal contexts where they are living, eating, exercising, engaging in recreational activities um, um, while they're in that deployed environment. Additionally, in those types of circumstances, if a provider is the sole mental health provider, they may have to conduct services with um, folks that they already have established relationships with. For instance, if someone is the sole mental health provider um, and they are working within the context of a medical group on a deployment, um, they may be the person to provide therapy services to their medical colleagues within their unit. Uh, Furthermore, when looking at military mental health providers, we look at something called dual or mixed agency. And here's where, um, for mental health providers in the military, uh, the patient is not the only client, right? So the military is also considered, and the military mission is considered the client as well. So this is happening simultaneously, and sometimes there's competing roles that lead to ethical conflicts. So psychologists, psychiatrists, social workers, counselors um, may operate also as an officer. So anybody who's a provider is either going to be in the civilian role or as an officer role. And these providers are really charged with balancing the needs of the individual with the mission and the needs of the unit and of the nation. We could also say that it's beyond a dual agency because mental health providers also have the last agent being the ethics code that they, by their specialty. And military law and regulations may require military mental health providers to deviate from these professional ethics. Uh, so some of these discrepancies between ethics codes and military regulations might be like historically, don't ask, don't tell, or the current ban on transgender troop serving. So if someone was a mental health provider under don't ask, don't tell, their role as an officer might have military regulations might have informed them to make that disclosure known, which would likely have resulted in the discharge of a lesbian, gay, or bisexual service member. However, that would go against the APA ethics code. And we might see this in current practice with the trans ban. Additionally, mental health providers within the military conduct fitness for duty assessments really at every encounter that they have with a service member. And if there are restrictions or limits to duty based on that assessment, they're required to notify the service member's commander about those duty restrictions. Whereas civilian providers outside of the Defense Health Agency are often discouraged from doing types of assessments like disability and forensic evaluations with their own therapy clients. So there's that added role that military providers have that civilians are often discouraged from doing. When we look at limits to confidentiality, there are more things that a military mental health provider would need to disclose that's outside of the typical limits of confidentiality that civilian mental health providers will often disclose. So within the military, commanders have what's called a need to know about a service member's fitness for duty, and that takes precedent over a service member's privacy needs. And then finally within this, we see that engaging in mental health care can impact a service member's career, both in the short term and long term. In the short term, this might be duty or mobility restrictions. So that could be limits on what duties a service member may be able to perform. So for example, arming status. If a service member um, uh, is required to carry their service firearm with them, they might be placed on a do not arm status based on a mental health provider's recommendation. They also might be temporarily restricted from sensitive or secret information, or have a deployment or a permanent change of station or PCS canceled or delayed. This is also true for deployments, temporary duty or TDY, or temporary additional duty, or TAD, which just might be short-term tasks or specialized training or just temporary staff augmentation at another location. Long-term career impacts could be administrative separation at the recommendation of mental health providers for things like personality disorders or failure to adequately complete a substance use treatment program, or recommendations for a medical evaluation board to determine if a service member meets retention standards. And results from that might be being medically discharged or retired. Or they could be returned to duty from that. But that also could have career implications about being returned to duty, but in a different military occupational specialty. So essentially having to change jobs within the military. And then there are also boundaries to competence that military mental health providers might find themselves in. So they might be in situations when they are unable to refer service members to another clinician that has that competence. This could be in situations where they're in a deployed environment and they may not have significant training or experience with a particular mental health concern, but as the only mental health provider, they might need to seek training and find consultation in order to provide that treatment for a service member in a deployed environment. All right. So with that, I mentioned that there are additional things in which mental health providers within the Defense Health Agency may need to make disclosures. One thing that is followed by DHA providers is the DOTI on command notification requirements to dispel stigma in providing mental health care services or mental health care to service members. And what this instruction details are the situations when providers are required to make these notifications. So harm to self or to others, and omission, right? So if they are experiencing mental health disorder or symptoms or concerns that might impair reliability or judgment, things that include impulsivity, that could interfere with their duty mission. Anytime someone is admitted into inpatient care or there are acute medical conditions that interfere with their duties, if they're enrolled in a substance use treatment program, if they are undergoing a command-directed evaluation, the results of that are disclosed to the commander. And then folks that are in what's considered special personnel status, so things like PRP, which is Personnel Reliability Program, which is used in all branches of service with duties tied towards nuclear weapons, just to ensure that personnel are reliable to perform those nuclear-related responsibilities. And those standards apply both on and off duty as well. And then there's this catch-all of other special circumstances. So when civilian providers off base are discussing the limits of confidentiality, these are also things that in good clinical practice and good ethical practice military mental health providers are sharing with their service members. And when these command notifications are required, what's recommended or required is to share the minimally necessary information to the commander. This includes things like diagnosis, information related to a treatment plan, what impacts are on the duty or the mission, and any recommendation for those duty restrictions, information related to the prognosis, um, information related to safety to self or to others, and ways that the command can help support or assist the service member's treatment. All of this is also couched within that minimally necessary information. So when you discuss the treatment plan, it doesn't have to go in depth into what that treatment plan entails, but can be the treatment plan is to engage in weekly therapy appointments. And with the diagnosis, if someone has a diagnosis of PTSD, it's not expected to disclose information like the index trauma. So now we've got some of that information couched in what are some of these ethical dilemmas and information that military mental health providers might disclose. Let's talk more about some ethical considerations when it comes to civilians. And to start with that, what I'm going to discuss first is looking at the APA's general principles related to ethics. So this as we've got these 5 general principles where, looking at the start is safeguarding the welfare and rights of those with whom they interact professionally and to do no harm or to minimize harm with the folks that they serve. So in the chat, what are some examples of times when we as mental health providers may cause distress or harm to our civilian patients? So not even looking at the military population. So if you want to throw a couple things in the chat, like when might we be required to do things that might cause distress or harm? Okay, exposure therapy, right? That can increase distress, particularly early on in something like prolonged exposure. Right, I'm saying abuse or neglect reporting, right? So when we're engaged in mandated reporting and we have a suspicion of something like child or elderly abuse, we are required to make those notifications and complete those reports, and that might come to distress or harm to the folks. All right, I'm seeing wellness checks, not disclosing information that they would like to know about their spouse that is also in treatment. Yeah. There's also things like duty to warn and Tarasoff, child custody evaluation, involuntary hospitalization. Okay. And then what might be some situations that might cause distress or harm to service members that we might be working with? Yeah, notifying command, yeah, do not arm, and records might bring up questions. When someone's on do not arm status, that might also be an indication to other people outside of the command that they might be engaged in mental health care. Now, that is not the only reason why someone might be placed on a do not arm status, but that might be an assumption that their unit might be making. Potential lack of professional advancement, not being clear about what information will and will not be added to their chart. Okay. right? So if there is information in the chart that they're not aware of, and that information is then shared with, let's say, the referring MTF, that might cause some distress, especially if that is information that then does need to be disclosed to a commander, or might result in the MTF making recommendation for things like do not arm, do not PCS, or deploy. For, let's say, our pilots, that might also come with a recommendation to for DNIF, which is duties not to include flying, or might be include recommendations for medical evaluation board or administrative separation. Then if we look at the next area for fidelity and responsibility, this general principle is really about establishing trust, managing your roles, professional accountability. And under this, when it comes to working with our service members, it's, are we able to demonstrate knowledge of military culture, or our willingness to learn? Are we clarifying our role? So are we there as a therapist or as an evaluator for fitness for duty or disability claims, security clearance? And if we're in one role as a therapist, what are things that, like, if it could potentially come up where they're being asked to also provide this other type of evaluation, that what would the role be? Is that something that someone would not do or would do, or in what situations? And then if the service member requests consultation between you and the Defense Health Agency, mental health provider, or their commander, are we clarifying with them what will be discussed and potential impacts of that? If we're looking at integrity, where honesty, accuracy, transparency comes in. So there's some overlap with what I just discussed, but transparency about your knowledge of military culture and regulations. Um, you know, with my own experience as a veteran, I might have a solid foundation of Air Force culture and regulations, but I might not have as much seeped understanding as with other branches, the Army, Navy, Marine Corps, um, into their culture and norms, right? And even within the Air Force, there are for any veteran or service member, there might be certain career fields that someone doesn't have as much exposure to, and therefore may not know the culture and the norms or all the special or duties that might be impacted. And in here, we're also talking about not making commitments or promises to things that may not be within your control. So if you do have to make notifications or consulting with a military provider, um, uh, and there might be something that you disclose, which you may not be in control with what they do with that information. Under justice, we're looking at fair access and equal quality care. So justice might mean for civilian providers showing up for members of the Guard or Reserve or active duty service members who are geographically isolated and may not have as great of access to uh, military or other civilian care. We're also looking at how lower TRICARE reimbursement rates um, might impact someone's willingness to become a TRICARE provider, and how rural installation locations might limit provider availability. I think it's also important for mental health providers to take precaution to ensure that they're aware of their potential biases as it relates to uh, the military and to service members, to explore their boundaries of competence that we'll get into a little bit later, and the limits to their expertise that do not lead to or condone unjust practices. And finally, when we look at respect for people's rights and dignity, we're going to be exploring privacy, autonomy, cultural respect. Um, and, this looks at confidentiality, self-determination, being aware of and respect for cultural, individual, and role differences, and considering how these factors, when working with members of different groups, including service members, to take time to examine our biases, like I mentioned before, that you might have about service members, the military, about warfare, and how this could impact your therapeutic relationship and the quality of care. And to also take into account the fear of career impact and to take that seriously and to not just reassure that away. Right. So that's just looking at the general principles. Let's take a look more at some of the ethical standards. And some things that I'll highlight are kind of what we've already mentioned before, but with privacy and confidentiality, competence, sections on human relations, record keeping and fees. And with this, I also want to just take a fictitious vignette and see how we can apply some of these ethical standards to a case example. So for this one, this is, like I mentioned, a fictitious vignette, um, but could be one that might be common for folks to see. So here we've got Alex is an active duty senior airman. She's an E4 who is a security forces specialist within the Air Force. And for folks who may not be familiar with security forces, these are folks that are responsible for safeguarding the people, property, and resources at every Air Force installation. So they receive training in law enforcement and combat tactics in order to defend the base, both stateside and around the world. Um, and so Alex is seeking therapy services for anxiety and depressed mood with you, an outpatient, non-Defense Health Agency mental health provider, off base. She noted that she is seeking off-base care due to concerns related to confidentiality. And she also described her squadron as unsupportive and has heard folks make negative remarks about other service members when they engage in mental health care. And so for some background, some aversive or unsupportive leadership and units have been associated with lower help-seeking behaviors as well. And she also noted that she is looking forward to an upcoming deployment due to potential career progress, that but that a deployment might help with promotion and other career opportunities. She also thinks that if she were to engage in mental health care on base, that she might be placed on a mobility profile, which might cancel her deployment. So just looking at the chat, any initial ethical concerns or things that you might want to be mindful of when starting work with Alex? Yep. So I see being clear with what info you must disclose and to whom. Yep. Similarly, upfront conversations about possible limitations to confidentiality, wrestling with fitness to serve. Absolutely. All right. So now let's talk a little bit more about privacy and confidentiality, as that was the first couple of things that people noted, right? So in the ethics code, maintaining confidentiality is there, right? We want to be discussing the limits of confidentiality with our folks and being clear about what the differences are between civilian providers and DHA providers. And having those conversations about if someone is engaged or if their MTF is aware that they're engaged in that, there might be certain requirements that they are asking from the service member in order to provide updates on their status and readiness. So what could be some of those limits to confidentiality? That may not be something that a civilian typically has to disclose, but if it's in their records and that those records are shared with the military treatment facility, what could be done with that? Within the ethics code, there's also things related to just minimizing intrusions to privacy, and only disclosing confidential information without the consent of the individual, only when mandated by law. And so some folks might be wondering, if they don't have a release of information to disclose information to a commander or to the DoD, how can you do that? Isn't that violating HIPAA? Well, HIPAA does have a military command exception. This allows both military and private sector providers to disclose the pertinent minimal information required to a member's chain of command when the information can impact the health and safety of the force and of the mission. It's also important to recognize with this that once that information is disclosed, that it leaves the jurisdiction of HIPAA. So if you were to share information with the commander, that information that was shared is no longer under the jurisdiction of HIPAA. However, their privacy does continue to be safeguarded by the Privacy Act of 1974. And what that means is that the receiving commander must restrict the use of that private information to only official military purposes, and they're prohibited from making unauthorized redisclosures of that information. So it's really, they're only to share that on a need-to-know basis. And if they're disclosing it with outside of the chain of command, then it really should be in writing who they are disclosing to. And when we've got these exceptions to HIPAA for military command, this is when we have the legal ability to make those notifications, but then it might come up against some ethical issues, right? And that's where we can face the ethical dilemmas. As we go back to looking at do no harm, you might legally be able to disclose information, but how do you balance that with the ethical issues of the harm that could come from those disclosures? One thing that's important to also recognize is, how did this person come to you? Were they referred to you by a DHA provider? Did they self-refer? Are they using TRICARE or not? So when mental health providers accept military referrals and accept TRICARE as the payer, they have agreed to provide records to an MTF as a part of the process of becoming a TRICARE provider. So you're agreeing to share those records. If you're out of network with TRICARE, you are encouraged to share those records, but it's not a policy requirement. Additionally, for folks that might be joining us from the VA, you likely are aware that VA records are shared with the Defense Health Agency clinicians through the electronic health record system. Now, civilian mental health providers who don't use TRICARE and accept out-of-pocket payment service members, they have no obligations to share records. However, they may have some duties to report medical and mental health issues that might impact their readiness and fitness for duty. And some of these things, when we're looking at weighing the pros and cons or costs and benefits of disclosure, we might look at harm to self, harm to others. And this might look different I'm seeing one question in the chat about differences in different MOS or different career fields within the military. So, and those might have different ways. So if someone um, is working in, um, let's say, contracting versus someone who is a pilot, there might be different levels of risk to others. If there is a pilot who is experiencing psychosis or substance abuse, there might be greater risk of harm to others if they were to continue to engage in their duties. It's also important to recognize that um, uh, folks, particularly within the Army, might receive a summary of care by non-military medical providers, a form that they would give you in order to fill out and for them to bring that back. Because it is part of their responsibility as a service member to report care and any fitness related issues. All right. So let's talk a little bit more about Alex as it relates here. And thinking about from what we shared, and I'll go back real quick to the vignette, is there anything that would initially need to be disclosed from what we have here? Not necessarily. We don't know if Alex meets criteria for a mental health disorder. We don't know anything about her risk level or impacts to uh, her ability to um, fulfill her duties. We assume that she might be on arming status, and risk levels might change what disclosures someone chooses to ethically engage in. We also explore how might your decision change if you diagnosed Alex with PTSD, let's say following her witnessing a fatal shooting related to an unauthorized person attempting to forcibly access the base while she's on duty at the gate. Well, when she mentioned that she's looking forward to an upcoming deployment, we might want to consider whether or not Alex has completed PTSD treatment and symptoms are considered in remission. If she hasn't started PTSD treatment, what is the potential for her functioning to deteriorate in a deployed environment where she might be experiencing similar traumas or the potential for them? Okay. So for situations like this, a clinician may choose to not report at all, which safeguards Alex's confidentiality and respects her goals. Um, and with her upcoming deployment, uh, and the potential impact from that is with an upcoming deployment, she's already noted that her unit is not supportive, and she may be deploying with at least a portion of her unit. And if her symptoms haven't improved, the deployment could be detrimental to her health and possibly the mission. If someone chooses to delay reporting, this kind of assures Alex's concerns with confidentiality are addressed. However, a solution may not occur within a reasonable time frame, and which could delay treatment and may lead to her deploying to an environment which may, again, increase possibility of deterioration. If someone then discloses to or decides to disclose to the commander or to the MTF, the military interests are protected, and she's placed on a mobility profile that might prevent her from deploying. However, she might receive treatment in a timely manner, but this might negatively impact her trust in the mental health provider and may increase stigma and may impact her career later on. Let's take a look at competence. And I see this from a variety of different areas. So this is the competence to treat concerns and disorders that are common with military members. We know from the APA Code of Ethics that boundaries of competence are highlighted, that mental health providers, particularly psychologists under this ethics code, provide services within populations in only areas within the boundaries of their competence based on their education, training, supervision, consultation, study, or just professional experience. Um, and so if we're looking, are you able to treat um, the concerns that service members are bringing with you? Um, we're also looking at cultural competence within this, right? In addition to being a service member, and what we talked about there, and being able to identify your own personal biases, your own knowledge of military culture and regulations, within that too is also looking at the individual and their intersecting identities. And so we also consider that service members and veterans make up a distinct subculture. And this is due to shared customs, norms, beliefs, shared language, and um, the cultural these cultural beliefs and norms can separate or provide distinctions between service members and veterans from their civilian peers. And so there might be significant implications for that for mental health providers. And in keeping with the ethical code, it is critical that mental health providers working with service members engage in training to develop experience, seek consultation or supervision to be effective with this population. And what I was alluding to earlier with like also individual differences, is important to recognize that the military isn't a homogenous group. Each branch has their own unique cultural differences, so do specific career fields, as do the service members and the population of the military, reflecting cultural differences of our country and beyond that. So things that folks can do to increase their cultural competency with the military is just increasing exposure to military culture, training, continuing trainings on military culture and regulations. The Consortium for Defense Psychology, which used to be called the Center for Deployment Psychology, has numerous trainings on military culture and military-related issues that are free and available to civilian providers. And it's also important to know the resources. To other military resources and providers. So in addition to the Warrior Care Network that Road Home is a part of, looking at Military One Source for non-medical counseling, military and family life counselors, primary care behavioral health within the UD, military chaplains, Give an Hour, Cohen Veterans Network clinics, Headstrong, are all different areas that you may not, or that you may be able to refer to if you don't feel like you can competently provide care to the service member. Okay. It's also important to note that research studies show that there have been recommendations just to increase MTF access to private sector treatment, so increasing access to records. So that's going to back to confidentiality, to increase staffing to managing private sector care, but also an increase in educating civilian mental health providers about readiness assessments. So if you haven't been trained in readiness assessments, you may not be competent and able to perform those without training and education and consultation. And that might be coming up in the future as there has been these recommendations to increase civilian mental health providers' ability to perform these readiness assessments. In order to also increase competence, I think it's important to look at some things that are related to military readiness. So I pulled this from the Air Force in a document that they had created to provide more transparency to service members and the impacts of various mental health concerns on their duties and careers. So you can see here at the top, these are disorders or situations that do not meet retention standards, and so retention and maintaining their career within the military is unlikely. So psychotic disorders, bipolar disorder, or mental health disorders that would require the use of a number of different medications, including lithium, for more than 6 months. So having some of this information about retention standards and things where, in conditions where it's unlikely and possible, or situations where they might meet retention standards but may not be able to deploy, um, might help with building the competence of a civilian mental health provider. All right. So going back real quick. Um, so if you don't know about the culture of security forces, or more broadly, the Air Force, how could this impact therapy with Alex? Any thoughts from the chat? Well, saying none, just some things that I think about is I mentioned arming use of force, um, and that if we're not aware of that Alex arms on a regular basis when she's on duty, we may not be aware of risk factors for her, or of her, um, comfort and training with firearms, right? I'm also seeing that in the chat, not being able to answer questions effectively, giving inaccurate information. That might also be that the clinician may not ask certain information or ask certain questions. They may be dismissive of you, feeling that you cannot relate. Absolutely. So these are things that just relate into competence. The next section of the ethics code relates to human relations, which include avoiding harm, multiple relationships, um, interruption of psychological services. So things just to be aware of, just we talked about before, that mental health providers take reasonable steps to avoid harm or to minimize harm when foreseeable and unavoidable. That multiple relationships can occur, especially when folks might be civilian mental health providers in rural or isolated areas. And they may be one of the few off-base mental health providers. And so it might be challenging to navigate those multiple roles. But folks are encouraged to avoid multiple relationships as much as possible. Um, And then interruption of psychological services is important to recognize with the military population, as there are a number of different things that can interrupt care or require um, help in transferring care. So this might be when someone goes on temporary duty status outside of a local area, or they're deployed, or they PCS to another location where you may or may not be able to continue to receive, or you may not be able to provide care, especially if it's out of state, if you're not a PsyPAC clinician or not in any of the other compacts. Um, and as it relates to not necessarily the human relations section, um, but as it kind of goes into the therapy section that I think is relevant here, is about a third of service members, when they are initiating care off base, receive concurrent um, mental health care with a military provider. So this might just include medical readiness assessments, concurrent psychotherapy, medication management. And so it's important for an off-base provider to examine that with their service members, determine what other treatments that may be receiving for the ethical considerations to discuss issues with the service member in order to minimize risk of confusion and conflict, and to consult with the other service providers when appropriate. All right. And then let's take a look at record keeping. For the APA Ethics Code, looks at documentation of professional and scientific work and maintenance of records. That documentation must facilitate the provision of services at a later date, either with the same clinician or with another professional. And so it's appropriate, or it's ethically responsible to maintain accurate documentation that someone else would be able to continue services with. Now, this does not mean that you need to include all details within documentation. So you may not need to include the details of an index trauma when engaging in PTSD treatment. You can ask yourself who might be accessing these records, and make steps to protect the client when others might have access or may gain access in the future. So does a primary care provider need to know about the details of a moral injury? How could those details be used if a commander becomes aware of it? And then having awareness of how electronic record keeping systems might communicate with each other. Does your record system share information with the Defense Health Agency and the VA? How do you discuss this with your patients? Do you provide them with information on how to opt out of that? Right. There's also a requirement to maintain accuracy in your reports, including to payers, right? So appropriate and accurate documentation that identifies the findings and diagnosis as it relates to TRICARE. Right? And so what if Alex requests that you don't document services or asks you to leave out information, including a diagnosis? Any thoughts from the group in the chat? No way. Saying notes can be crafted in a way using language that protects them. Right. So being thoughtful about the impacts that language and what's including in the note could have on the service member if that is disclosed to an MTF or to commander. There may be no need for diagnosis for insurance reasons. All right. Yeah, and so what I'm saying here, yeah, explain the need for a diagnosis and accurately reflecting the care and findings that is being performed. All right. So I'll leave with some additional recommendations. I think it's important to ask yourself what is in. Oh yeah, I'm seeing another one. Providers have an obligation to uphold professional standards. Absolutely. So always ask yourself what is in the service member's best interest. Maintain awareness of your own competence. Pursue training and education related to the military mental health system. Have a really good informed consent, I'm saying from the chat, absolutely. Seek consultations with mental health providers who have experience working with service members. Remind commanders, if you have to disclose information, of the Privacy Act when doing so. Disclose the minimally necessary information. To discuss limitations to confidentiality at the onset and continuously. Someone may have no concerns to information being shared at the start, and those might be developed later on, and also vice versa. So if the person does not want information shared, they might want information shared at a later date for a variety of reasons. And so continuing to have that conversation so that they have an awareness of the limits there. Share the need to know information. Absolutely. I think that falls into the minimally necessary information. To review guidelines for professional associations. So both the APA, both American Psychological, American Psychiatric, the ACA also have guidelines for practice with service members. And just to be attuned to your own levels of well-being and distress. And that's going to be true when working with service members and civilians. But we know that when our own well-being deteriorates and we are in greater level of distress, we may be at greater risk of making ethical violations. All right. And here are the references that I used throughout this. Recognize I sped through a little bit at the end, but wanted to make sure that we were ending appropriately at time. So I want to thank you all for your time and participation in the chat. Yep, I'm saying some additional things about ROIs. They can resend their consent to that. Absolutely.
Thank you so much, Dr. Hiner. Hello, everybody. My name is Dr. Joel Wyatt, and I'm the training program manager here at the Road Home program. Thank you all so much for attending today. We will have future talks, much like this one, aimed at increasing competency and knowledge around serving veterans, service members, and their families. In the chat, you'll notice from Chris Miller, there's some resources. One, if you are claiming CEs today, the link is there. That was also sent to your email. Lastly, there's a link to our website where you can access previous recordings of trainings, as well as take a look at upcoming trainings. And then the slides are also available. If you have any questions about any of that, we'll stick around for a few minutes. Please drop them in the chat. Or questions for Dr. Hiner, if he has a few minutes, can stick around. But thank you all so much for your participation today. I see someone has a hand up. Feel
Yes,
free
it's
to,
me. Yes,
yeah.
it's me. My hand was up for you. I was asking about the CEUs because I've done other trainings, and there was a little difficulty in. I mean, went through the training, but there was difficulty in accessing the CEU certificate. So, can you explain that again? Maybe I was having some challenges.
Yeah, so all the instructions should be in that document. You need to set up an account with Rush University Medical Center, as this is the agency sponsoring the CEs today. And then once you make that account, you'll be able to enter the activity code and create the hours. Was there a particular point where you were stuck?
Well,
Perhaps,
I've done a couple of trainings just like this one,
yeah, of
and
course.
was instructed to go to the communication that was sent. And when I attempted to do that, there were some challenges, and so I just chucked it up.
Okay.
But you say I have
Um,
to create an account with Rush University.
Yep, which is all in the link that I believe Chris has put in the chat and might be redropping in the chat.
Okay.
Um, but yeah,
And
let
you
me
said it was sent to the email though, right?
also, so your registration email, the email came like right before this webinar
Right,
began.
right,
As a
right.
reminder, the link is also there.
Yeah, and I think I registered for Rush University previously, maybe about during the
Excellent.
pandemic, because that's how I got introduced to your trainings. All right,
What?
thank you very much.
Yeah, no problem. Thank you. Any other questions before we wrap and close the Zoom for today? I see is only available for social workers and psychologists today. Although you may be able to submit the handout to your licensing board and gain credit as an NP or other mental health professional. Same thing with counseling. Oftentimes there is some reciprocation between the agencies. Sure, if you could contact Chris Miller, his email is in the chat there as well. Chris can help you with the CEs and accessing the forms. Yeah, want to make sure you get your CEs. All right, y'all. Well, thank you, Dr. Hiner. I hope you all have a wonderful rest of your Wednesday, and stay tuned for more presentations coming from the Road Home program. Take care, everybody.